Okay, here's another interesting point as to why we might want to keep the pulp. Look at this column. These are papers from Belgium, from France. Loftus is actually Irish. So this is a UK paper. Turkey. Root-filled teeth with apical periodontitis is a cross-sectional study. And what I want you to take from this is that 53% of root-filled teeth with apical periodontitis, 40% of root-filled teeth with apical periodontitis. So if you read this graph, you may actually begin to think the root canal disease, not treating it. And the reason for that is that we do not carry out root canal treatment well in general practice. It's a fact. There's a massive range of technical skill that does root canal filling teeth. So if you're looking at trying to save a tooth for a patient, or you're wanting to save the patient, vital pulp treatment may well be a more viable option. Another thing I like to add at this point is that root cause was the main issue. So it was a video on Netflix. I don't know if anybody actually watched it. I didn't watch it. Root canal treatment was responsible for anything from breast cancer, I think, to depression, to England's cricket team losing, and et cetera, et cetera. And I think one of the problems about root cause is that it kept referring to root canal treatments, ripping out the inside healthy part of the tooth, putting in an inert filler that was still had infection inside it. And it doesn't play into the hands of this way of saying, look, endodontics and dentistry is not looking at that anymore. We're looking at regenerative techniques. We're looking at harnessing stem cells and trying to build up this image that we're actually doing something in dentistry which is not necessarily all black, all destruction, and all about putting in things which, like root canal treatments, which always have a bad connotation. So I think in order to address some of this, press, we can't address all of it. We should be more proactive in trying regenerative or minimally invasive techniques. This is a slide I quite like. It's a motif. You can see this little chap here, little chap on his face. These American companies which store dental stem cells from kids' deciduous teeth. You'll all be familiar with this. And what is, I don't highlight it for that reason. I highlight it for the reason that we keep forgetting that patients are now aware that pulp contains stem cells, teeth contain stem cells. So by addressing treatments or potential treatments, and vital pulp treatment is one of those, that utilizes this progenitor cell population, we are in fact looking as if we're being sexier, if you like, in our dentistry. We're addressing these new challenges which medicine has taken on long since. So it's another good reason to say we're investing in a lot of time and thought into this area. It's not new. Nothing's new. This is a paper from 1945, which basically suggested, why are we actually taking out traumatic pulp or other pulp exposures when in the other parts of the body we don't do this? So nothing in dentistry is new, but it does highlight, and it's highlighted since 1945, the recuperative power of the dental pulp. What we have now is we have better materials and we have better understanding. So we have less excuse, in my opinion, not to be embracing some of these techniques. Slightly technical, but we have to kind of remember how the pulp repairs. This will bore a lot of you. I get quite excited about this, but it doesn't excite so many other people. But deep caries here demineralizes dentine. Dentine here is a reservoir of all these growth factors, bone morphogenic protein, TGF-beta, a range of matrix metalloproteinases. And these are leached out and enter the pulp and stimulate this reparative response, which causes tertiary dentine. So therefore, this either existing odontoblasts create more dentine or new odontoblasts create a new bridge, or things we should be utilizing. But we cannot utilize them if the inflammation is not controlled. So vital pulp treatment is about stimulating repair and controlling inflammation. And when we think about how we do it, that's what we're trying to work out. Okay, let's ask another question here. I think there's another question, Kev, about, I'm interested in what factor influences most your decision to keep the pulp. And I want really one answer here. Is it the age of the patient? Is it the symptoms, pulpal bleeding, carious depth, or would be arrested for a person, a dentist who did vital pulp treatment?
I try and be a bit as inclusive as possible with the answer options, Hal. So I had to throw in a few extra options there.
No, that's no problem.
Yeah, okay, cheers, man. And I assume you're talking about here when you're in treating a tooth, are you? And it needs this work.
I think you've got a patient who comes in and they've got a large caries lesion and they're complaining of toothache. What would make you think I can keep that pulp, or what might you make? What would be the main thing you would say? Oh yeah, I'm going to do vital pulp treatment because it's a young patient. I'm not going to do it with an old patient. And there's a few factors in here which play in our mind that we should think about.
Okay, here we go. I'm going to share it.
Yeah, I mean, I think that's actually right. I think I'm glad to see that most people think that age isn't a problem. Symptoms and diagnosis, I think, is the key. Related to the caries depth, some people still really like caries depth. Pulpal bleeding. Well, a lot of people have spent a lot of time looking at that as a what you'd call a proxy marker, because there's no doubt if you drill into a healthy pulp, and I've spent quite a lot of time drilling into healthy pulps as parts of research studies, it doesn't bleed at all. In fact, very often you don't even know you're in the pulp. So this bleeding is a sign of inflammation. But it's not a reliable indication of the level of inflammation, unfortunately. Patient cooperation at 7% is interesting. So I'm glad to see that. I thought that would be higher than that amongst this group, but it's not. So I think that's good. Okay, Kev, let's move on to that. Okay, here's a case. 18-year-old patient. Grade symptoms for deep carious lesion. You can see that here. It would be deep, verging on extremely deep. The tooth is not spontaneous, but present when drinking hot or cold drinks into sweet stimuli. The tooth is slightly tender to percussion. Does that affect our decision making? Perhaps. And responds positively to pulp sensibility testing. During selective carious excavation, you expose the pulp and the bleeding is present. How would you treat this tooth? Now, you might be concerned about the percussion. You might be concerned about the hot sensitivity. You do note quite positively that it's not spontaneous. You notice an 18-year-old patient, although that has not reliably been shown to make any difference in terms of outcome. Although, oddly, all studies use young patients because they think it will, but it's not been shown. So you may decide in here that that's deep. Possibly we could do a root canal treatment with a closed apex. I can do this quite nicely in one visit. Or you may reckon that pulp's vital. It doesn't seem like irreversible type pulpitis, or if it is, it may be only irreversible in the coronal aspect of the tooth. I may do some sort of pulpotomy procedure here. But there's a few factors that might vary. If it had said the pain was lingering, if it had said the tooth was acutely tender to percussion, if it had said that the patient was 72, these things may affect your decision. Some of which shouldn't. I'm not sure age should. I think tenderness to percussion may well, because it implies the inflammation is spread to the apex, although that's not reliably been shown. So it makes us think about all the things that make up our mind for decision making. But the first thing you've got to get is some sort of diagnosis in your head of what that pulpal condition and periapical condition is. Other questions you might want to know or think about: is the type of exposure significant? Yeah, absolutely. This is a traumatic exposure. This is a carious exposure. Pulp cap or a partial pulpotomy. Even if the pulp has been exposed for 3 to 4 to 5 days, believe it or not, the pulp can sustain that. The biofilm is only the surface. As long as you remove the surface of the pulp, and I'll talk about that later, that will heal quite nicely. Carious exposure, we don't know how long that's been contaminated. It's usually a sustained bacterial onslaught for several months. And very often that, therefore, as a result, does not do as well as traumatic exposure. Okay, so the type of exposure is significant. The size of the exposure in traumatic makes no difference and has not been reliably shown to make a difference in carious exposure, oddly. Age of the patient, unfortunately or fortunately, is not a reliable indication of how these will go. Level of bleeding, one study showed this was linked to outcome. Matsua at 1986, I think. It was a very small study. It's not been reliably shown since, but it's a useful measure. Can you control the bleeding? Because if you cannot control the bleeding at all, after 3 or 4 or up to 5 minutes with cotton wool soaked in sodium hypochlorite, say that again, cotton wool soaked in sodium hypochlorite, 2%, 1%, press the pulp, leave it there, remove it every minute. If the pulp does not stop bleeding, you have two options. You either take all the pulp out, do root canal treatment or pulpectomy, or you take more tissue away and you try to arrest the bleeding again. If you get down to a full pulpotomy level and you cannot arrest the bleeding after 5 minutes with pressure with sodium hypochlorite and cotton wool, go to a pulpectomy. Okay? That's the rules of thumb we are using at the moment. Because if the bleeding doesn't stop and you apply the material on top, you will struggle to get a result on that. Is the material used significant? Yes, I think it is, and we'll go on to that later on. We'll discuss that a little bit later on. Is the technique significant? That's what I mean by technique. I mean pulp capping, partial pulpotomy, or full pulpotomy. There are indications for full pulpotomy. There are indications for pulp capping, but only traumatic. When it comes to caries, I wouldn't do pulp capping. Partial or full pulpotomy. Is the pulp exposure time prior to treatment significant? As I've said before, up to 3 to 4 days for traumatic exposure, you can actually cap these teeth. Okay. Just some questions, just some quick answers. Bigger question, I suppose, is that pediatric dentists, there'll possibly be some pediatric dentists in the line tonight. If they can listen this time of night, I'm sure they can. Hate the pulp exposure. They're very frightened of pulp exposure. So are cardiologists. Endodontists like pulp exposure because they're used to it. But I've always asked a bigger question. The studies of Lars Bjorndal and a lot of these other big cardiology studies make their negative finding pulp exposure. The pulp was exposed, that was a negative. But is it actually a negative compared to treatment? There, I've shown that before. This is Lars Bjorndal, randomized control trial, looking at these various methods, and he found that pulp exposure was a disaster. Success was down to about 20 to 30% for pulp capping in his study. He didn't use sodium hypochlorite. He only pulp capped teeth that he literally fell into the pulp. And if it was excruciating pain, he still included them in the study. So there's that study, I like Lars, he's a friend of mine, has got some flaws when looking at the pulp capping group. But nevertheless, he found very poor results. So he found that pulp exposure was a negative prognostic factor. Miguel Marquez did a study. Now he's a skilled chap. He uses some magnification, loops, I think. He uses sodium hypochlorite and he places MTA on all caries exposures, some with symptoms, some without symptoms. And he has success rates after 3 to 4 years of over 90%. So his conclusion was that pulp exposure is not a negative prognostic factor. It's how you handle that pulp. You handle the tissues well. Can you place gently the restoration? Can you remove all the caries? Because although you might have a selective caries response when you're looking at deep caries, you might leave some soft dentine. If you expose the pulp, you must remove all soft dentine. There's a difference then, because you don't want to leave any possible way that the pulp will get reinfected. So my view on that is that the jury is still out. At the minute, we don't have good evidence to suggest exposing the pulp is a disaster. As long, this is the key, the treatment is carried out well of the pulp exposure. Yeah.
Can I interject a second?
Of course, anyone, yeah.
All right. Now I'm after getting a question in from Demetrius Emmanuel, all right? And he comes back to the point that you made earlier on, and that was about the key prognostic factor or the key influencer of decision. And the correct answer seems to be signs and symptoms or pulpal diagnosis. Then you went to describe the bleeding as the key influencer of your decision, treatment decision.
It's not a key decision, the bleeding. It's a practical decision. The key decision, if you go in and if the patient is indicative of a normal reversible pulpitis. Now these are difficult terms, as you well know. These terms don't always relate to the actual histological appearance of a pulp, but they're good indicators now, really, of some degree of the pulpal inflammation. So if it's normal, or it seems to be normal, or it's reversibly inflamed, I think a vital pulp treatment, or even avoiding exposure, is the right treatment. If you're getting an indication that the pulpitis is more than that and it's moving towards irreversible pulpitis, you may well be a little bit more cautious about vital pulp treatment, but the new studies are showing that we can do it in those cases. What I was actually talking about was that when you're actually managing an irreversibly inflamed pulp, or what you think is irreversibly inflamed, there will be some cases you just cannot stop the bleeding. And if you cannot stop the bleeding, it might be the time to say, look, I could not stop the bleeding in this case. I went to pulpectomy. So that's a practical, on-the-ball decision rather than a key. If you quite nicely stop the bleeding and it looks like healthy tissue, fine, then place your pulp capping agent or your pulpotomy material and get out of there. But if it keeps bleeding and you can't control it, it's time to think of a pulpectomy.
And if the diagnosis earlier on had been coming back with a poor prognosis, you would have went for a full pulpectomy in any way.
Yeah, I mean, I think if the patient, if you put a little bit of cold or you vitality test that tooth and the patient jumps and it lingers and they say they've been kept awake at night for the last couple of nights and you go into that pulp and it's bleeding, but you can control that bleeding, I still think you can, and we'll come on to this a little bit later, you can go on, you can say, we'll do a pulpotomy in this, we'll just take out that coronal pulp material. The ones I'm worried about are the ones that are absolute agony. They've not come to see you. It's been like that for 3 or 4 months because there's almost certainly some necrosis in there at that stage.
Yeah.
That's
okay. All right, Hal, go on, we'll let you go. Carry on.
Yeah, evaluate success. We'll briefly go through this because what we actually talk about generally are clinician-based outcomes. In other words, does it heal in the radiograph? Does it respond to vitality test? Or does the root continue to develop? Patients aren't really so interested in that, of course. They're more interested in, is the tooth still there? Is it pain-free? And does it look okay? You know, is it not discolored? Scientists, particularly pulp biologists, are more interested in histology, which may have absolutely no bearing on clinician and patient. And when we look at vital pulp treatment, it's probably wise briefly looking at all these things and to see what sort of success we have. This is success for a patient clinician. This is a patient, one of Roberto Caradu's patients, who's an endodontist in Dublin. And look closely at this tooth here and this tooth here. These were both deep caries. This one actually was, he didn't have the extremely deep caries here. And he treated both of these with pulpotomies, with a calcium silicate material. I think it was biodentine. These are the pictures below after 6 months. This is healing well, it's got vitality response, it's fine. This has also got vitality response, but look at this. See this internal resorption that's developed? You may argue that's a success for the patient because that patient is in no way complaining of pain, but that's a dentist failure because if you continue that, if you leave that the way it is, that will continue. That's a very unusual appearance. It's only one I've ever seen, but it does show a little bit of a deviation between what would be the patient would consider a success and what we consider a success. Within the guidelines, we suggested for following up vital pulp treatment, you would monitor by history and clinical examination 6 months, 1 year. Only if really the symptoms were persisting or there was some uncertainty regarding healing should you continue to assess them. Cold and electric pulp testing or sensibility testing should monitor the pulp response, but if you do a full pulpotomy, these are partial pulpotomies. If you do a full pulpotomy, the teeth may be unresponsive. You will not get response to vitality testing after a full pulpotomy. One day, see the bridge. So you can sometimes see those on radiograph. Okay. How reliable the clinical test? This is a partial pulpotomy. This is a full pulpotomy. Partial pulpotomy, some people are now using with patients of irreversible pulpitis. And an advantage of using this in patients with irreversible pulpitis is you will get a positive vitality response. Full pulpotomy, you won't. If you put something cold or hot against this tooth, you will not get a response. So there's an example of a full pulpotomy with an amalgam on top in this instance. You put something cold against that tooth, you won't get anything. So the only way you can assess success is by tenderness to percussion or radiographic assessment. That's different from a partial pulpotomy in that you can also do hot or cold test or electric test. So you can get a little bit more information from those. There are studies when teeth with irreversible or signs and symptoms of irreversible pulpitis, both are possibly study, and both have shown success. The pulpotomy studies have probably shown slightly higher success, as you might expect, because they take away all real risk of there being inflamed tissue left that may be left under a partial pulpotomy. But there again, this may be an easier technique to do. We'll come on to the success rates in a moment. Okay, so that's another interactive one, Kev. I'm really interested if people could actually think about how successful, based on how I've explained success, is full pulpotomy in patients with signs and symptoms of irreversible pulpitis. Signs and symptoms of irreversible pulpitis, of course, are prolonged reaction to hot and cold, or spontaneous pain, or keeping the patient awake at night, or maybe some tenderness to percussion, although that's not necessary. Lingering pain, you know, as apart from reversible pulpitis, which would be off and on to thermal. Okay. Yeah, interesting. Yeah, good. So most people are in that category with a range. Okay, yeah, good. Well, let's look at this. Let's look at this. There's been about 6 or 7 studies. This year we published a systematic review with the Birmingham group and the Belfast group, looking at the pulpotomy for mature teeth with symptoms of irreversible pulpitis, a systematic review. That was this year in the Journal of Dentistry. 12 months of the studies, and there was 4 studies, all with irreversible pulpitis, just irreversible pulpitis cases. After 12 months, the clinical success was 97, 36 months 94. Radiographic success after 3 years was slightly lower, just under 90%. So really quite good results for clinician-based outcomes of full pulpotomy. Was there any cases excluded? In other words, if you look at these studies, was there any cases that they didn't treat? Yes. If the pulp showed signs of necrosis, in other words, there was pus present in the pulp when they went into the pulp, or they could not control the bleeding. That was what I talked about earlier on. They did not enter into this trial. But cases that they could control the bleeding and there was no sign of pus, they placed the material, restored the tooth, and these are the success rates they got from 1 year to 3 years. So actually quite impressive. Using a pulpotomy. Okay. So this may well be successful in cases, if you like, of partial irreversible pulpitis in the coronal pulp. We do need some better long-term randomized data, but this is very, very promising, I think. What I would say about this is that now the term irreversible pulpitis is a wrong term. I mean, you cannot be partly dead. You know, you can't be partly inflamed. So what we're really saying is that this is localized irreversible pulpitis. Diagnostic terms in endodontics. I don't think we want to do what Perio's done and go away for 3 years and come away with the most complex classification system known to man. But we do certainly need to think of a new way of, a helpful way of classifying pulpitis. So there's the success rates there. Okay, scientific-based outcomes. I will only touch on this. This is research I was involved in because scientists are into histology. And there's no doubt, this is, on the right we have calcium silicate, MTA. On the left we have a hard setting calcium hydroxide material, dical. Some of you, this may be the material you're actually using. It's still the material a lot of people use. This is MTA, but you could use biodentine or proroot angelus, or sort of MTA angelus. And you can see the height of the repair over the pulpal exposure compared to the dical. It's a much nicer material to use on the pulp, without a shadow of a doubt. So how important is the capping material? Let's have a little think about that. In terms of how important the capping material is, it's not the most important thing, actually. The most important thing is the level of inflammation and how we actually control that inflammation. So if you put the nicest material in the world on top of that inflamed pulp, the pulp cap is not like if you remove it either by a partial pulpotomy or a full pulpotomy, dry the pulp, place your disinfectant, dry it, place your material. And we recommended, and you can see this quite clearly, we recommend now a hydraulic calcium silicate material. That is the new guidelines. Should be placed directly onto the exposed pulp prior to definitive restoration. So in other words, what we are talking about is proroot MTA, or biodentine, or angelus MTA, or microamiga MTA, or one of those plethora of now materials. The only perhaps one I wouldn't recommend is Theracal, which is a resin-based MTA, which is set by curing light, because the resin is not kind in the pulp cells in comparison to the other calcium silicate materials.
So Hal, if I can ask, for people who don't have these materials,
yep,
what would you use in a general dental setup?
If you don't have access to these materials, the other options would be, I guess, calcium hydroxide-based materials, which could be hard setting like Dical or Life, or non-setting like Pulp Dent. Now, I have a real problem with hard setting Dical and Life because the minute you put it against something wet, it sets. It's very frustrating material to use on a wet surface. It's resonance-based, so it's a disaster. The non-setting materials like, for example, calcium hydroxide, and you could use calcium hydroxide non-setting like ultracal, and you could flood that area there. Okay. The problem with a non-setting calcium hydroxide is obvious. Unless your seal is good, it will wash away. But still, some people are recommending putting a layer of that on, and either a glass ionomer on top, or even a zinc oxide eugenol. But if you put zinc oxide eugenol directly in the pulp, it tends to cause some surface necrosis of the pulp. So if you do not have access to a calcium silicate material, like one of the ones I've indicated there, then I think the other option would be, probably the best option would be a non-setting calcium hydroxide, because I've had real problems in pulpotomy, that is, with setting calcium hydroxide like Dical or Life. You can use Dical or Life in a pulp capping scenario. It's a small exposure, you've got a dentine basin beside it, you can try and do it there, but it's still difficult to get a proper restoration. I'm asked this question a lot. Are all these calcium silicate materials, and there's loads of them these days, are they all the same? This is a little bit annoying, this area for me, because we've got resin-based composite, we've got amalgam, we've got glass ionomer. But this is called, because it was patented by Mahmoud Torabinejad. You may have heard of Mahmoud Torabinejad. He's a prolific researcher from Iran who's now based in America. He named the material after himself. Mahmoud Torabinejad aggregate. He patented it, so the material became MTA. But the actual genre of materials are hydraulic calcium silicates. Biodentine is also a calcium silicate material. It just has a different radial pacifier. That's important. This biodentine material sets much quicker than MTA. This also, MTA Angelus, sets quicker than ProRoot MTA. This material doesn't contain bismuth oxide, so biodentine is much less discoloration. But its radial opacity is the same as dentine, it's difficult to see. So if you're doing a pulp application, I reckon that because you want to avoid discoloration, biodentine is not a bad option. It sets much quicker, about 12 to 18 minutes or slightly longer. This takes several hours to set. So you have to put it in there and then gently put something on top of it. But in essence, in terms of biological response, it appears that the response is similar. So you can use and pick and choose which material you would like to use within this group. But the recommendations are still saying use this group. One question about materials before we come off materials is if the pulp is not exposed, you may want to use a glass ionomer, in other words, indirect pulp cap or deep caries. You can use biodentine. Is probably as good. The research isn't definitive in saying that these calcium silicates are better than glass ionomer. The one thing I'd like to see people avoid is if you've got deep caries and you remove the caries, is not to put a composite resin directly on that. Noticeably, I said deep caries. If it's medium or shallow caries, I'm not worried. But deep caries, the reason why is the resin is pretty harmful to pulp cells. So you want to try and, to some extent, mediate that response in the pulp. I know Giuseppe Camilleri and others, who I know Giuseppe well, go around saying that you should not place a lining under a composite. But I'm a lover of pulp. And if you're close to pulp, you should try and protect it with a glass ionomer. Only if it's a deep caries lesion. I don't use Dical anymore. I use just a little bit of Vitrabond or something under that just to protect the pulp. Okay, I think it just to brighten it up, I'll go through a couple of cases here just to tell you what we practically do. Here's a lovely, beautiful exposed pulp. You see that? Beautiful. That will have a biofilm on there, of course, the surface. That's been exposed. This is a patient from my Glasgow days. Wasn't so uncommon to see this on a Monday morning. This was not a trauma. This was opening a bottle of beer, not being hit with a bottle of beer. And you can see that pulp, beautiful there. Patient walked about for 3 days like that. So you'd imagine that. So what do we do in a case like this? Well, the first thing we do is we isolate that. Asepsis is critical. You can then rinse that whole area over with hydrogen peroxide if you have it, or iodine if you have it, or sodium hypochlorite if you have it, but rinse it with something. Then you can see this nice, there's a little bit of a fracture here. You can see the pulp here again. You could put the material directly on top of that, the pulp cap. But what I would do in a case like this, I take a high-speed burr, loads of water coolant, a carbide burr or a diamond burr, barrel burr, and drill straight into that pulp, underwater spray, and cut a trough of about 2 to 3 millimeters. See that beautiful surgical wound compared to what it was like before? Now, you've removed that biofilm on the surface. In addition to that, you've created a nice little access cavity. And there you can place your material. In this case, product MTA, but you could use biodentina. You could use a calcium hydroxide-based material. You place that in there. Okay? See how it's fitted into the little sort of pulpotomy, or some might call it, in traumatic terms, a spec pulpotomy or a partial pulpotomy. Then you restore that with your composite or whatever else, and then you keep that under observation as we indicated before. Okay? What I should say and didn't say at this point, I would rinse that with quite a large volume of sodium hypochlorite. I would not use saline. I would not use Costal. I'd use 2% sodium hypochlorite and rinse it as much as you can. Because the studies we're seeing now are tending to indicate that you should use a disinfectant. It will not damage the pulp. It will not dissolve the pulp, but it will disinfect the surface of the pulp. To make sure the bleeding is stopped, as I said earlier on, a little bit of cotton wool, sodium hypochlorite soaked, press it in there and leave it for a minute and then check it every minute. But you can see this is stopped. Sometimes when you place this material here, you get some bleeding around the side of it because it soaks into material. I don't worry about that. That very often happens. Okay.
Hal, can I ask then, we've had some questions coming through.
Sure, perfect.
The rubber dam isolation, is that a must for these type of procedures, or is, because I suppose for our patients sometimes it might be a bit tricky to get the rubber dam on?
I know. I understand. Well, I mean, I think again it's going back to root canal treatment, vital pulp treatment. We had an argument about this when we did the consensus document, because the Danish and a lot of the Europeans said it was an absolute essential to have asepsis with rubber dam. But the Swedes and other groups said it was more important to carry the procedure out well, and that it wasn't always possible to place the rubber dam. So my answer to that question is it's much easier to do it with rubber dam, and it's much better to do it with rubber dam, but it may not always be possible. It does make your job as an operator a good bit more difficult if you don't have rubber dam on, but I appreciate that it's not always possible to do it.
Sometimes we might be doing these under general anesthetic as well, where we can actually control the moisture. So would that be acceptable?
That's also acceptable. Yeah, but general anesthetic's a little bit different, isn't it? Because there's a few variables, as you say, you can control the moisture a lot better. You can put your fingers in places where you can't normally do in general anesthetic. Yeah. So, yeah, absolutely. The only difficulty with the general anesthetic, you've got to protect the airway anyway, so that's protected as part of it. So as long as you can manage that, yeah, that's okay.
Okay.
So that's a partial pulpotomy that we indicated there. Here we are with another case, deep caries. In this case, we removed, as we said before, all that caries and exposed the pulp. Okay, what I would do in this case is much the same. Take a burr, just clean out the inside of that. Okay. Place your material, restore. And here's a nice X-ray case. Here's a case which we would call deep caries. Okay. We have some widening here, but this tooth is still responding positive to vitality testing. It's exaggerated, but it's not crazy toothache. Here we do a partial pulpotomy. This is actually our MTA material. You can see we've taken out some of the pulp horn in actual fact, and we've restored that tooth permanently. This can still be vitality tested as normal. Now we'll look at it again, and you can actually see 6 months later, you may not see this area is actually reduced. So this presence of an area does not necessarily mean the pulp is necrotic. What it means is there can be bacterial toxins here, leaking down here and causing this. So although it does reduce the prognosis a little bit, the apical widening, it does not mean the end of the pulp. We've seen quite a few cases in vital pulp treatment respond positively to this type of treatment. A question I get quite a lot is, when do you choose partial and when do you choose full pulpotomy? Generally speaking, if the symptoms are of the nature of irreversible, hot, cold, sustained, keeping the patient at night, I think a full pulpotomy is a better, more predictable bet, because at the minute the research on partial pulpotomy is more preliminary. But that may change in the future, but at the minute that would be my view on it. Here's a full pulpotomy case, again, deep caries. You take all that out, you come into the pulp. This is interesting. How do you remove that pulp tissue? You cannot use a high speed like I did in the anterior case and go because you're going to really damage that tooth. If you use a slow speed under water coolant, you will tear that pulp a bit. So what you've got to do, and what I've been doing a lot, is I've used some scalpels and some very sharp excavators, spoon excavators, and cutting the pulp, slicing the pulp, surgically, cleanly cutting the pulp. If you agitate that pulp and then push it down and compress it, you will damage the pulp. So this is one of the skills in full pulpotomy, is carefully removing the pulp from this part of the tooth before you place the material. Avoid high speed and posterior tooth, sharp excavators, scalpels, blades, surgical cuts is what I'm talking about, rather than tearing or ripping.
Does that take a bit of practice? Does that take a bit of practice?
Yes.
That sounds hard.
Yeah. Not what to do. Dentists hate doing this, Kev. Dentists hate doing this. Is you need to get an extracted tooth and you need to open it up and muck about with the pulp. I as you know, handle so much pulp. We have a lot of pulp we cut up for experimental reasons, from teeth, all sorts of teeth, to culture. And it's quite difficult to cut a pulp in two unless you use a very sharp blade or a sharp excavator. And you hold it and you cut it. If you use something like a burr, it just whips it around like a bit of sausage. So you've got to practice a little bit how to handle the pulp in there. High speed for a partial pulpotomy, high speed for an anterior tooth or even a premolar tooth. When we get to molar teeth, we have to think about using excavators or scalpels. That's the trickier bit.
Yeah, I think it reminds me of the body snatchers. You know, these guys who were digging up all the cadavers when they were learning how to do anatomy. that was from your neck of the woods. So I think it's interesting. Well, someone else after commenting as well about the water in the fast handpiece. If it's non-sterile, is that an issue?
I used in Dublin Dental School is supposed to be the best water in the world, but in actual fact, no. No, it isn't. Because in actual fact, you can more or less put any amount of water in that. What we're worried about is a biofilm contamination. So we're looking at leaking saliva, pooling in there, and it being sealed in there. The water, whether it's completely sterile or not, I don't think anyone's shown that makes a difference. Your last rinse of that pulpal surface will be sodium hypochlorite anyway, so I wouldn't worry about that. Okay, there we go, restored. Of course, as I said earlier on, you cannot vitality test that, so we're looking at radiographic assessment. Okay, yeah, here we are. One more interactive one. I suppose what I'm really wanting to ask is, finally, is if we don't undertake vital pulp treatment, why not? Kev, can you throw that question up if you have it there?
Yeah, I totally didn't have that. I found it there. People are answering that now, Hal. Just while people are answering that there, just if you can give us an answer to another question that's come in briefly. And it's one about, can you clarify when exactly a pulp cap procedure is recommended versus a partial pulpotomy?
Yeah, I have a straightforward answer to that. I would only do a pulp cap if it was a traumatic exposure.
Perfect. And then
I don't see the advantage, Kev. If you get a chance, the pulp, it's got a caries exposure, you get a high speed, a partial pulpotomy can very easily be done. And it just gives you a bit of insurance. You've cut away the really inflamed piece of pulp tissue. You've removed that bit of dentine. You should do it if you get an opportunity.
Okay, we're going to take a step less invasive here. It's pretty much the same question, but one step removed. Would you sooner, it's from Sinead, would you sooner go to partial pulpotomy and remove all the caries rather than leaving caries around the pulp and do an indirect pulp cap? We're walking backwards.
Yeah, no, it's a very good question, because that divides the profession. If we've sent a couple of papers for review at the International Endodontic Journal, where people have looked at partial pulpotomy in exactly the circumstance you just described. Deep caries with moderate symptoms have been done a partial pulpotomy. Some reviewers will reject it out of hand, saying it's over-treatment. That's, I think, a nonsense, because as we said earlier on, you can actually probably remove all that caries and do a partial pulpotomy. My view would be, if the symptoms indicate a normal-ish pulp or a reversibly inflamed pulp, I would tend to just go with leaving some softer firm dentine. The cases I would do a partial pulpotomy is if the dentine is still very soft over the pulp, and almost inevitably you're going to expose the pulp there. you just go ahead, remove all that caries, and do a partial pulpotomy in those cases.
Thanks, Hal. Here's the results for your poll.
Is just what we're discussing tonight. It's not a particularly well taught part of the undergraduate curriculum or the postgraduate curriculum. And part of the reason is we teach lab mannequins which use plastic teeth. On the clinic, we see these as almost occasionally, and therefore there's no real structured teaching on it. So people don't always build up a great deal of knowledge or expertise in this area. And it tends to leave people not quite sure if they should be doing what they're doing or they shouldn't be doing what they're doing. So I'm not desperately surprised to hear that. Lack of predictability is also, I think, I can understand everybody saying that, because if something in your hands works well, and the obvious one is an extraction works well, why would you take something that's got potential of failure in a patient who's difficult to manage? But to some extent, that is dentistry. If you want to be a defensive dentist, then I understand that too. You could barely say that more or less everything needs to be either removed or beyond the fissure sealant. And I think all of us have to find a balance here between the patient and the scenario of choosing the cases to do this on, at least at first.
I think you're spot on there, Hal. If I can just add in, there's some work from Danny McGowan on this field, and what she's found is that dentists have a tendency, especially under general anaesthetic, and when I say dentists, I mean us special care dentists, we have a tendency to remove, and I think there used to be an old saying when I started dentistry, if in doubt, whip it out. And it never becomes, the stakes are never higher than when someone's waited 4 years to get a general anesthetic and you don't know if they can report pain reliably afterwards. And there's been that tendency for predictability. And I think what's needed, just as you were saying there, is I think we need to become more comfortable with a lack of predictability, because if we're looking for predictability, we will inevitably overtreat. And I think that's the problem. So in a way, we need to change the criteria for success. So we will fail. And that is probably a indicator that we are making better decisions. Anyway, Hal, back to you.
Yeah, we're nearly done now, I think. This is actually following on directly from what Kev was just saying there. This is a paper that I find quite interesting. I think Alison Dougal's talked to me about this in the past. It's a French group who are special care dentists, I believe, talking about endodontic treatment performed under general anaesthesia. And I'm asking it, should we treat, following on from treat disabled patients or difficult patients differently? And their thoughts are interesting on this. Patients with equal needs should have equal access, equal quality of treatment, and equal treatment outcomes regarding of what procedure is used. Recent findings regarding the success of pulpotomy, which we've just discussed tonight, for permanent teeth with both reversible and irreversible pulpitis means that this treatment should be considered as part of the therapeutic arsenal when treating a patient under general anaesthetic. I agree, but that's kind of what we were talking about. When treating patients under general anaesthetic, this technique is particularly useful for vital teeth with deep caries, as it allows the pulp vitality to be maintained, avoids provision of lengthy root canal treatment for difficult cases, and avoids the overuse of extractions. I think that says the issue quite nicely. And I think the root canal treatment bit is interesting, because very often we're nervous about doing root canal treatment because we maybe don't have the equipment or the time or the facility to do that in one visit under general anaesthetic. So we opt for the extraction in a situation like that. But this does, these cases with reversible and irreversible, it does offer a third option, in my opinion. And it's something that we won't resolve tonight, but it is something to think about. Are we doing patients a service with predictability, or would we be doing them a bigger service by offering equal treatment to others? Food for thought, I think.
Yeah,
anyway,
for sure.
In conclusion, caries conclusion spelled wrong. Caries remains a considerable management of operative dentistry, and I think so. Minimally invasive solution should always be considered. I think now, if you go to see a doctor and he gives you an option of doing a small keyhole procedure or ripping your knee apart, you'd look at them as if they're mad, suggest they would rip your knee apart. So we do need to think about minimally invasive options within dentistry. Vital pulp treatment should be a strong component for patients with disabilities. I believe it should be. I mean, totally aligned with the French group in that. I think it's something that really should be at the forefront of discussion within disabled special care dentistry and behavioural difficulties with patients. There is a learning curve, and I think you can see that in some of the things we discussed here. There is a learning curve, but I think the rewards can be huge for both dentist and patient, actually. And I think we need to think about deepening understanding of the response. I get really upset within the dental curriculum these days because I think we become less and less scientific and more cosmetic. I think when dental students and dentists need to be much more aware of the possibilities of science and how they might be incorporated into dentistry. Anyway, that rant aside, thank you very much for listening. I'm just people with here in Dublin and in Belfast and Birmingham and New York and in Rutgers and New Jersey. They've contributed to some of the slides and a lot of the proper intellectual property behind us. So thanks very much. I'll leave you with that slide. Thank you.
Well, Hal,
Oh, I'm there. Lost you, Kev.
there we go. Sorry, I did. Ah, damn it! I was I was telling my jokes to myself. All right, well here. Yeah, so basically, look, we've got lots of stuff to go through, lots of issues after horizon here. I'm going to encourage everybody to, anybody who wants to stay on for a chat is more than welcome. Any pedodontists online, it's past your bedtime, and don't worry, we'll fill you in what happened afterwards. I suppose if I can go through some of these questions, Hal, I think this would be interesting. One of the ones that's come up here, and it's quite similar to what you're talking about there, and that's that. I'm wondering whether when treatment planning for a GA, would you be concerned that the vital pulp therapy may fail, meaning that the patient may need a repeat GA soon afterwards? So I've from working with you, Hal, I've started doing vital pulp therapies, as you know.
Yep.
And it is scary when you're doing them under GA, I'll be honest
Yeah, I
with you.
agree.
And you're kind of thinking, oh my God, am I making like, is this going to be a repeat GA? Now, I've worked in the private sector where each GA is about €1,400, and it's on and it's on my shoulders if there's a repeat.
Yeah.
So it could wipe out my profit for a month. So I still do these under GA privately, and the only time where I've had to do a repeat GA was actually when I opened up and took out a whole pulp, and I couldn't get the canal dry at the end. So in fact, if I'd avoided pulp intervention there, I probably would have ended up having less repeats. But there's a fear there. There really is a fear.
Yeah, I think one of the fears, I think it's a very good point, and it's not something I encounter all the time because I don't treat under general anaesthetic, as you know. I mean, what I would say, first of all, and we say the same to patients or to students and to recent graduates or to established graduates who are doing rotary instrumentation, nickel titanium instrumentation. The cases to choose at first are cases that you're comfortable with. All the patients you'll see in your office will range from being very unmanageable under GA to more manageable to reasonably easy to manage. You should start off these cases in patients that you know, you're familiar with, and are reasonably easy to manage, because they're the patients to work on first of all. You can probably treat them under intravenous or nitrous, and therefore it's much easier to. So once you start getting confident in the procedure, you feel it's going well for you, then you can say, hold on, this is going well, I'm getting good results, I'll move this to GA. I think to plow into GA the first time, I think, I'm going to try this, and it goes wrong, you'll probably not do another one again. So I would do it as a gradual. I don't think you're disserving patients that way. You're just making yourself more confident with using it. But I understand the risk there, absolutely.
Yeah, I think it's a big issue, but I think we do have to be brave, Hal. I mean, for our patients' sake, so we can, because we're not the ones who can't chew after the GA. We're not the ones who lose the facial height and lose the aesthetics. You know, it's our patients. And when we go home that afternoon after the GA, it's not something that we have to live with, I suppose. You know, so, and we can justify it. We can say, oh well, you know what, vital pulp therapy isn't a sure thing in my hands. I went for the extraction for the patient.
Yeah. Yeah.
Okay, well here, Rebecca's after coming in here, she said that it's difficult when treating under GA with our patient groups, as often we can't take it to our history. We're unable to get vitality testing, And so you're left with only part of the picture, the radiographs and the clinical picture when you go in. So how do we determine whether or not to do pulp therapy in
Yeah.
these situations?
It's a good, I mean, very often these patients, you will probably guess that they're having some sort of toothache, but the very fact that they're with you or there's a complaint there. The caries in those cases, you may well have a radiograph. I assume you would have a radiograph in those patients. Maybe that would be difficult, but you may have at least a panoramic radiograph, which you can assess the depth of the caries. If the caries looks as if you're likely to expose that pulp, in other words, it's deep towards extremely deep, when you go in there, you may well expose that pulp. And I think you can go through the sort of steps I described earlier on. You will remove a good bit of that pulp tissue and you will use the sodium hypochlorite soaked in bleach. Or somebody asked, if you can't use sodium hypochlorite, what could you use? I think the next best thing to use would be Corsadil soaked in cotton wool. And you can leave it there and you can see, can I arrest that bleeding? Does that pulp tissue look as if the bleeding and the hemorrhage stopped? And if so, then I think you can manage that with a vital pulp treatment. I don't have a problem with suggesting that. The cases you go in and the bleeding is just ridiculous, you cannot stop it, or indeed there's some signs of necrosis or pulp, or pus in the pulp, I think you can say, no, that's not going to work. And you have to either commit to taking the tooth out at that stage or doing a pulpectomy, depending on what sort of time or resources you have to do that. That would be my best advice in that. But you'd certainly need an x-ray and to be reasonably comfortable assessing the pulp tissue and the hemorrhage of the pulp tissue.
Which is very useful. I think that's very useful advice. We are getting people coming on saying that that under GA they feel that the conditions aren't right for this therapy. That actually the anaesthetist is against it. They don't like us taking over the airway with the rubber dam. So it's great to hear you giving suggestions for use without rubber dam. And I'd like to challenge I'd like to challenge, as I've challenged my own thoughts on this treatment, Hal. I'd like to challenge people who are sitting there thinking, oh, this treatment isn't for me. This treatment isn't for my patients. And I'd like to encourage you to use Hal's kind of stepwise approach to developing the skills from your extracted pulp right through to your patients with behavior management through to GA. And for your patient's interest, try and give them the best chance at that microsurgery rather than the amputation. Okay. Well, look, Hal, let's go with another question here. Does direct pulp capping and partial pulpotomy have similar success rates for traumatic exposures, or does partial pulpotomy give better success?
Traumatic exposure, by definition, almost should be an uninflamed pulp. The inflammatory change in a traumatic exposure will be superficial because it generally is very often an unrestored tooth or a lightly restored tooth in which the pulp was healthy before it had this immediate traumatic event. The case I showed earlier on highlighted a partial pulpotomy in a traumatic exposure case, an incisor. And the reason for that is it's practically easier to do that. And if you go back to Švek's work, that's Švek, C-V-E-K, I think he was from the old Czechoslovakia as it was then, he suggested that the Švek pulpotomy was advantageous for practical reasons. He got very good success with it because it was much easier to apply the pulp capping or the capping agent and restore the tooth. There's not a definitive study actually anywhere which shows it's much more successful. But if I was doing it and I had a traumatic exposure in whether it be a canine, an incisor, or even the premolar, I would do a partial pulpotomy because in these traumatic exposures, the teeth tend to fracture obliquely. And if they fracture obliquely, the pulp tends to be at the level of the fracture. You don't want the exposure at the level of the fracture, you want it below that. So you take the pulp below the level and then restore it from that. So although I don't think you'll find it in the literature, I would always recommend a partial pulpotomy during a traumatic exposure.
Okay, lovely. I have a hand up from Alison Dougal, and I don't know if she wants to talk online here, but so I've turned your microphone on there, Alison, if you want to chat. If you don't, I'm going to ask Hal some questions about materials.
Yeah, it's a mistake. I'm sorry.
Okay, sorry about that, Alison.
Ah, jeez, how disappointing, Alison. I thought you would say something very interesting.
It's always good fun to do the video camera roulette where I just put on people's random videos to see what they're up to.
Yeah, I can imagine what Alison's dressed in at the minute.
All right, Hal, it's materials for you, okay? We've got a few questions in here. And the first question is, what is the optimum concentration of NA, of sodium hypo? for these?
Well, it's an interesting one. I mean, in the dental school in Dublin, we are using 2%, which it can only be approximately 2%. We're using a Milton solution. The reason we're using a Milton solution is now you have to use a material or an irrigant with an SDS or a form which gives you all its risks. In other words, you can't go any longer walk into Tesco's and just buy thin bleach and use it on the patients, which we used to do in root canal treatment all the time. So we're using 2% bleach, Miltons, and we're using it undiluted. And the reason we're using it undiluted is because it will be less than 2%. Every time you open that bottle, some chlorine comes off and it's less than that. And in a vital pulp treatment, that's fine. The Swedes use a 1% solution, a Dakin solution, a balanced solution. But in vital pulp treatment, that's not been shown to make much difference. Some of the Americans, I don't think you can get it here, the Americans use 5% sodium hypochlorite, which is pretty cytotoxic. I wouldn't recommend you need anything above 2%. 2% Miltons, or even dilute it to 1%, I have no problem with that. That's the sort of concentration we should be talking about.
And in the absence of sodium hypo, you're talking chlorhex?
Chlorhex, yeah. I think saline has got no antibacterial worth a damn. So I think you should, beyond that, chlorhexidine. And some studies have done that. There was a study by Kudzina from Norway. She did a study using chlorhexidine, and it seemed to work quite well. But I think in general terms, sodium hypochlorite, number 1, chlorhexidine, number 2, which you may want to use if you don't have a rubber dam one, of course. You may not want to use sodium hypochlorite.
Okay. Biodentine, does it take long to set before you can put your glacionomer on?
Well, according to the manufacturers, it takes 18 minutes, or did they say 12 minutes? We done a study in this recently, and we found it takes a lot longer than that to set, which can be a little bit awkward. But in my view, when I say set, we took set as if you put a probe into it and you can go into the material. My view, it doesn't matter much. There's plenty of moisture there from the pulp to let it set. If you're concerned about setting or you're in a rush, cover your biodentine, which will be fairly firm. It won't be maybe set firm, with some glacionomer, and build the tooth up with whatever you want to restore that with. Because in the old days of pro-root MTA, it took 3 to 12 hours to set. I used to still cover it with calcium glacionomer and just restore the tooth. I never worried to wait about the set. It's set enough. The thing you can't do is profusely rinse it, because you'll wash it away. So if you're going to etch and bond the tooth afterwards with a composite, let's say, you'd be better putting a layer of glacionomer there to prevent washout. That's the only thing I would suggest. Okay.
So let's say if someone's under a GA, you'd throw in your biodentine, let it set until it's hard enough to the touch. Don't wash it too much, glacionomer over, and then you can build whatever you want.
You can do whatever you want, absolutely.
Okay, lovely stuff.
You could use Fuji 9, you could do a light cure, and any type of glacionomer, it's not too important.
Okay. Another question then is about cuspal coverage. Is there a recommendation for cuspal coverage after vital pulp therapy?
Yeah, it's a good question, that, because we get asked that a lot, because it's an indication, because as you know, if you do a posterior tooth, either a premolar or a molar with root canal treatment, there is an indication you should put a cuspal coverage restoration on that. The research is not really there for vital pulp treatment. When I mean vital pulp treatment, I mean full pulpotomy. I think if it's a partial pulpotomy or a pulp cap, there would be no indication for cuspal coverage. My view is that you probably don't need to do cuspal coverage in general cases. And the reason for that is you've kept the pulpal tissue in the roots, so you've retained some of that proprioceptive feeling within the roots, so you don't probably generate as much force in these teeth. The only exceptions I would have about that is if it's an MODBL restoration and you're there, it's probably wise to do some sort of, maybe not necessarily a crown, but some sort of either onlay or plastic restoration which covers the cusps. But you may do that anyway. But there's not an absolute necessity after vital pulp treatment to do cuspal coverage.
Okay. While I have you, we're going to get a bit more information now, Hal, before I let you go. And that's this. A lot of the general anesthetics that are undertaken in Ireland, they may not have radiography. And I think it's one of the reasons that the endodontics is generally not considered an option. Would you see vital pulp therapy as a viable treatment option without radiography?
Yeah, as long as you have a pre-op, and I'm guessing you have a pre-op. I guess you're talking about, in other words, before they've had the GA, you can't even get an X-ray.
No.
That can be difficult. I mean, you can try it. You are obviously a little bit in the dark because you've no idea the level of the depth of decay. Having said that, if you go into one of those cases, and this is what I call real skillful dentistry or real practical dentistry, you go into tooth because you know there's caries there. You're managing that caries, you expose the pulp. The pulp starts to bleed. We can go through the same routine as we went on earlier on. I mean, I think it's a shame because you're condemning that patient based on purely on behavioural and some degree of defensiveness, just to say that tooth's doomed. You may just go through the same stages. You may remove all the caries in that case, remove as much pulp as you can, see if you can arrest the bleeding. I don't see why not. Once you're in the tooth, you can get a lot of information by simply handling and visualizing the pulp.
Okay. Hal, I think we're going to leave it there. I'd like to, on behalf of the Irish Society for Disability and Oral Health, thank you very, very much for sharing your expertise and for giving us a fascinating insight into the exciting world of endodontics. And I'd like to thank you very much for taking the time and sharing your expertise. And I'm going to finish with a little plug, and that is for our next webinar. And this webinar is going to be a fascinating occasion. We have a unique perspective on oral cancer from a dentist, a periodontists who have a lived experience of living with uncurable cancer. So this is going to be a unique insight into the emotional journey that is often missed when we consider what there is to learn about oral cancer and our management of patients with oral cancer. We'll of course be covering the basics like risks of osteoradial how to avoid that, and how to deal with that, and the other topics around oral cancer. So after this webinar, everybody who's been online will get an email tomorrow saying thanks for joining, and there will be a link to the next webinar in that email. So if you can all, if you'd like to join us, you'll be able to click directly from that there. And as I said before, we are the Irish Society for Disability and Oral Health, and we are a group that is part of the International Association of Disability and Oral Health, who are having their once every 2 yearly, I don't know if it's biennial or biannual, I'm not sure, but once every 2 yearly meeting in Acapulco in Mexico, which sounds absolutely balmy. So I'll be there, and I'm sure many other people online tonight will be there, and we hope to welcome you all with us for what will be a lovely time in Mexico. So, sin na bhfuil cháirde, sin deire leis an oíche, gur míle mágat Hal agus gur míle mágat de gachtainine atá tar éis teacht an seo nocht. Íomhá agus bannacht é libhar fad. Okay. Yeah. Kia ora, Graham. Kia ora, Graham. Yeah, go for it, Simon. Yeah. This is the future. This is the future of our discipline in dentistry. These are our technical skills. So, and we're at the forefront of that. So the occasions like this are really opportunities to bring our dentistry and the dentistry for our patients forward. So go with it. Okay. All right. Here, well, Gachtainine, thanks very much, everyone, for coming on. I hope I got to all your questions. I hope you enjoyed it. Please join us next time.